Next speaker will be Dr. Teemu Karjalainen. Progression of Dupuytren's contracture, secondary analysis of a randomized controlled trial comparing surgery, needle, no, I got the wrong one, I think.
Yeah, I gave it yesterday, so there was a confusion with this.
Oh, okay, sorry. So Dr. Teemu is going to talk about what he wants to talk about. Thank you.
Probably not. Okay, so good afternoon. So the audience requested me to change the topic, so here we go. So I'm using data from, in this talk, I'm using data from the same trial that I presented yesterday. I'm trying to tell what we learned about measuring the treatment effects in this disease when you are treating it. So I have no relevant conflicts of interest. So the options to measure, we can of course measure the contracture angle. We can use upper extremity specific prompts, or we can use disease specific prompts. And then we can use all kind of global improvement or symptom state questions. When we are talking about measuring, the first and foremost important thing is the reliability. So when you go to and you measure how tall you are, if your first measurement is 1 meter 55 centimeters and the other one is 185, so then you really don't know how tall you are. So it's important that we get the same results between several measurements. Then it needs to measure what it's supposed to measure, which is validity. And in this study, we were focusing on responsiveness, so how well the measurements capture the change in the health state. So we have data from multicenter RCT, which I presented yesterday. So we have 302 participants. They were randomized to surgery, needle, or collagenase, and we had a follow-up at 3 months and 2 years. So our objectives were, we were asking which outcome measures discriminate best between the treatments. So if we know that there are some differences between the treatment and the outcomes, and if we want to find those differences, we want to ask which outcome finds those differences. So we had self-reported global rating of change on a Likert scale. We have a self-reported patient-accepted symptom state. Are you happy with the state of your hand? Residual contracture angle and proportion with at least 50% release. Then we had DASH. And according to some study, one study, DASH seems to load on 2 factors on factor analysis. So we were thinking that maybe this DASH function, so the items 1 to 6, would be more responsive. And then we asked perceived function on a VAS scale, which is just one item question, how well is your hand functioning? Then we had generic health quality of life and composite outcome, which combines the angular release and pus. So it's successful treatment if patient is happy and she has at least 50% contracture release. The other approach was that we were looking at which continuous outcome has the best longitudinal validity, so which correlates best what the patient is feeling globally. So if patient is feeling that I improved a lot, much improved, so which outcome correlates best with that perceived improvement. And we were looking at the residual contracture DASH, generic health-related quality of life and VAS function for this. Regarding the methods we used for discrimination, we used for binary outcomes, we calculated the risk difference. For the continuous outcomes, we standardized by using the standardized, calculating standardized mean difference for all outcomes. And then for longitudinal validity, we calculated the Spearman's correlation with the global improvement. And then we were looking at the signal-noise ratio. So the less there is noise and the stronger signal means that if you are using this outcome in your trials, you need smaller sample size. So we calculated standardized response mean for the outcomes. So first we look at the binary outcomes. Looks like the success, which is the composite outcome, combining the subjective health of state and the contracture release, found the difference with the global rating best in surgery versus needle, Surgery versus collagenase, again, success quite good, global rating okay. Then needle versus collagenase, again, global rating and success, so the global outcomes were discriminating best. So what about continuous outcomes? Total residual contracture, so the sum of MP, PIP, and TIP joint, and MP joint found the largest differences between the treatments, whereas the PIP didn't. And the same with the all comparisons. So what about the longitudinal validity? The correlation of change on the score versus the global change, and what we see, quick dash function symptoms or total score doesn't correlate very well, so it doesn't capture the change that well. Whereas the VAS function, which is only a one item question, seems to be better than the VAS questionnaire. Then the health-related quality of life, not so great. And then of the angular measurements, total passive extension deficit, and the MP joints seem to perform best. So conclusions, the composite outcome seems to discriminate best between the treatments, and our composite outcome was patient-reported being in a patient-accepted symptom state and had at least 50% release to make it binary outcome. Contracture angle has the best longitudinal validity, and lower signal-to-noise ratio, it transfers to lower sample sizes in trials if you are using this as your primary outcome. DASH seems to be suboptimal, which we already knew, and it looks like it doesn't help to divide it into subscales of function and symptoms. But the simple one-item VAS function works better, so if you want to ask for function of the hand, it might be better to use just simple one-item VAS function. Thank you.
Any question or remark? No. Yeah.
You haven't looked at the URAM or the Southampton score?
No, we haven't. We didn't have it in our Finnish language, and we thought that it's a bit of work to start translating and validating the questionnaire, so we sort of made a shortcut in there.
Thank you.